Hello everyone. Today we will discuss about hypernatremia. So whenever we see hypernatremia in any patient, how to evaluate practically. So hypernatremia is serum sodium level of more than 145 milliequivalents per liter. So when we get this value, we should have clear picture of three things. That is, whether the individual is elderly individual. Second one is, we have to keep in mind about diabetes insipidus of central cause, central variety and peripheral variety. So diabetes insipidus of peripheral variety, that is nephrogenic. So these three things should be cleared. Based on this only, it is very easy to evaluate and manage hypernatremia. So we will see one by one now. Suppose the individual is elderly who has presented with hypernatremia. Generally, they will not be able to reach for water. Most of the times they will be bedridden or suffering with some illness. So they will not be able to drink enough water. So there will be non-reach for water. So history is important. Then there will be lack of thirst. So decreased thirst, or there might be extrarenal losses. For example, they might have developed autonomic dysfunction or some other condition which is leading to excessive sweating. So in that also they might be losing more water than sodium. That might have led to hypernatremia. So some extrarenal loss, again common in elders. So here major problem is decreased level of water intake. That's why these individuals will have decreased urinary volume, urine output, and because of low level of water in the body, kidneys will try to preserve more water, leading to concentrated urine output. So if we get urine osmolarity, it will be more, generally more than 800. So this will be the picture. When we think of central diabetes insipidus, this can be because of multiple reasons which have led to decreased AVP production or ADH, antidiuretic hormone, decreased production. That can be because of multiple causes in the CNS. For example, tumors or some inflammation, even vascular aneurysms, most commonly anterior communicating artery aneurysms, even hydrocephalus, or even trauma. So these mechanisms might have led to decreased production of antidiuretic hormone. That's why the person will be losing more and more urine, that is water. So they will be having increased urine output, commonly more than 3 liters per day. So they will have polyuria, and this urine will be dilute urine. So urine osmolarity, if we get, will be lower, that is less than 500 in this case. And when we come to diabetes insipidus of peripheral cause, that is nephrogenic diabetes insipidus, often the individual will be of young adult age group, young adults, and there might be history of exposure to some metals, heavy metals such as lithium, or there might be hypercalcemia or even hypokalemia. So these are few things which will damage, the sites where antidiuretic hormone will act, that is distal tubules and collecting ducts. So even though there is normal production of the antidiuretic hormone, it will not come and act at that particular site. So again, kidneys will not be able to concentrate the urine. So the individual will lose more and more dilute urine. Again here, there will be increased urine output of more than 3 liters per day with urine being dilute, that is osmolarity will be less than 500. So in both we are seeing the same picture. So if we want to differentiate these two, we have to do desmopressin test. So desmopressin test will help here. Desmopressin. So we are giving desmopressin either intranasal, oral, or even IV supplements we have to give and look for any changes. Suppose there is improvement in the urinary osmolarity after giving desmopressin, that will suggest there was lack of ADH. So after supplementing, it has improved. So it will move towards central diabetes insipidus. Reverse happens in nephrogenic. Even if we supplement desmopressin, it will not be able to act if it is nephrogenic diabetes insipidus. So there will not be any improvement in the urinary osmolarity. And we can get imaging of brain to look for any structural lesions which we have listed out in central diabetes insipidus. So this is how we have to consider evaluation and investigations. Coming to the management proper. So here, first column in elders, if there is lack of water intake, the treatment will be just supplementation of free water, either oral or through NG tube. We can even give IV fluids, mainly 5% dextrose, but be careful with hyperglycemia. So this will suffice whatever the lack of water intake was there. Whereas in central diabetes insipidus, as there is decreased ADH, we can supplement with ADH, that is desmopressin, either oral or intranasal or IV can be given. Coming to nephrogenic diabetes insipidus, here we know few things, that ADH is there, but it is not able to act at distal tubules. That's why the individual is losing more and more water. So if any correctable causes are there, we have to treat that. That will solve the issue. So treat the cause. Otherwise, we can try with few things. For example, we can give amiloride. So how does it help? It will block ENaC channels. So there will not be any chance for lithium to do its action of disturbing concentrating ability of the kidneys. So this amiloride will help in nephrogenic diabetes insipidus, especially if it is because of lithium induced. Otherwise, it will not help much. Then comes usage of thiazide diuretics. This will just complement by helping in reabsorption of more and more water in the proximal tubules. So helps with water reabsorption at proximal tubules, PCT. So it is not the direct action at the site of problem. It will act at different site and try to compensate the balance between sodium and water. Similarly, we can make use of NSAIDs. They will block prostaglandin production and indirectly affecting on the concentrating abilities of the kidneys. So like that, thiazide diuretics and NSAIDs are not acting at the site of problem. They are just helping in nephrogenic diabetes insipidus by some other mechanisms. So these two can be used in chronic nephrogenic diabetes insipidus, not in acute nephrogenic diabetes insipidus. We cannot utilize this mechanism. There, whatever the underlying cause is there, we have to try to find that cause and treat that properly. So this is the overall thing about hypernatremia. Just to summarize, we consider hypernatremia if serum sodium levels are more than 145. Then immediately when we see this picture, we have to have 3 columns clarity. That is, if the individual is elder, take the history whether the individual is not able to take enough water. Then just free water supplementation is enough. And in that case, individual will be having less urinary output, which will be more concentrated. So urinary osmolarity will be more than 800. Then comes central and peripheral diabetes insipidus. Central diabetes insipidus mainly because of decreased ADH production because of multiple structural lesions in the brain. So that will lead to non-concentration of the urine in the kidneys. So individual will pass more and more dilute urine. So there will be more urinary output and osmolarity will be very less. And we can get imaging done, or we can do desmopressin stimulation test so that the concentrating ability or osmolarity of the urine will improve. So desmopressin is the treatment of choice here. Coming to peripheral nephrogenic diabetes insipidus, here levels of ADH will be fine, but that will not be able to act at its site of action, similar to insulin resistance seen in diabetes mellitus people. So here we have to try with some other mechanisms so that we can balance sodium and water. So we can make use of thiazide diuretics, which will act by helping more reabsorption of water at proximal convoluted tubules, and we can try with NSAIDs, which will act by using alteration of the kidneys concentrating ability. Otherwise, we have to focus on the proper cause, which is disturbing that concentrating action at the distal tubules or collecting ducts. So once we get these common causes, if anything is there, we can focus on correcting that, mainly hypercalcemia, hypokalemia, or some medications and heavy metals. So this is the overall thing about hypernatremia. Thank you so much.